Hello, namaskar everybody.
Kashmiri चालू कर.
Good evening all. A warm welcome to all of you. I feel privileged to extend my warm welcome to all the participants and all the eminent speakers who are there for today's program. I welcome you all on behalf of Maharashtra Indian Academy of Pediatrics, President Dr. Ramakant Patil sir and Honorary Secretary General Dr. Amol Pawar sir. I welcome you all for this forum. 2nd April marks the World Autism Day, and it is an important reminder to raise awareness about the autism, its impact on the individuals, families, and community. On this World Autism Awareness Day, we should strive to bring the awareness and help create an understanding of how autism affects the people. We usually say it's an emerging condition, but now we are supposed to say that from emerging to emergency. So the theme of the World Autism Day is empowering parents, the vital role of pediatrician. So based on that, we have arranged this wonderful academic session, and we have eminent speakers with us. We have with us Dr. Samir Darwai sir, we have with us Dr. Jaya Shivakar madam, and Sonavne sir as a speaker. And also we have a dignitaries with us, Dr. Ramakant Patil sir, President Maharashtra IIP, Amol Pawar sir, Secretary Maharashtra IIP, Dr. Bodhankar sir, Dr. Jaya Shivakar madam, and Dr. Samir Darwai sir, Treasurer Central IIP. And the chairperson for this session is Dr. Anand Deshpande sir. So I welcome you all. Now I request Dr. Ramakant Patil sir to address the meeting. Ramakant Patil sir.
Yeah, good evening.
Good evening.
To all the speakers, my friend Dr. Samir Dalwai, our patron, Dr. Bodhankar sir is seen. Pranam Bodhankar sir.
Namaskar.
Namaskar. And all the faculty and delegates. This is a wonderful idea about increasing the awareness. If we increase awareness in pediatrician, the pediatrician by themselves will be increasing awareness in parents. And secondly, there is a debate whether autism incidence prevalence is increasing or whether we are becoming more aware. But I think there is a definite rise of autism cases. In addition to awareness, it is a definitely increase in incidence prevalence of autism. And if we are aware, pediatricians themselves and if parents, so severe case of autism will be brought to the moderate case will be made to mild, and mild case may be made to not without autism. And early intervention will definitely improve the outcome of autism. And we have got stalwarts who will tell us whether they will grow out as a normal adult, and how we can empower the parents for treating this autism. So I don't want to take you up much time, but I congratulate again all the EB members of Maha-AP, along with Secretary Amol, Dr. Neha Singh, and Dr. Kashmiri Badbade, who is also a very active participant. And I welcome and thank Dr. Samir Dalwai for accepting and assenting for the talk, along with Dr. Shivalkar madam and our own Dr. Ravi Sonone. So I acknowledge presence of my friend Dr. Anand Deshpande also here, and who is also one of the moderators in this. So over to you, Neha. Who is conducting it? Neha, are you conducting it or somebody else? Kashmiri.
Kashmiri is conducting.
I don't want to
Kashmiri,
take
unmute yourself.
over to Neha.
Kashmiri, unmute yourself.
Yeah, thank you, sir. And now I request Bodhankar sir to address the meeting.
Hello, good evening to all of you. I am an accidental invitee here. I came here specially for Ramakant, Amol, Jaya Shivalkar, and my friend philosopher Dr. Samir Dalwai, Sonone, Rashmi, and all people. When I saw it today, this is my third webinar I am attending. 4 to 5 was there. DIP, then there was 4 to 5 another one, and now it is one interesting one. The topic is going to be, I think, great academic piece. I would not like to take your time, but I really welcome Samir, I welcome Jaya, and all the esteemed speakers, Sonone sir, and all these things, and Chairperson Ramakant Patil, Anand Deshpande. They are going to tell us really, because to be very frank, I talked with Samir also in Gandhinagar. We are getting nowadays many cases which mimic mild ASD only because of overuse of mobile phone or over screen, because of COVID. So I think I would like to listen to them than to talk him. And thank you, Ramakant Patil. Thank you, all the best.
Thank you, sir. Your presence means a lot to us. Thank you very much. Now I request Jaya Shivakar madam to address the topic.
Good
Jaya.
evening all, and thank you for having me here on this platform amongst the stalwarts like Dr. Samir sir, Dr. Deshpande, and everybody here. Thanks to President and Secretary Maha IP for taking this issue to grassroots level, because it is very important for pediatricians to be aware of this problem so that they can handle these day-to-day issues. And sometimes there is a little bit of hesitation in pediatricians' mind whether I can handle this or not. So in that reference, I think this seminar would be very useful. So thank you so much for having me here.
Thank you, ma'am. So without wasting much of a time, I guess we should start with our session. So today's first speaker, I would like to introduce him. It's my privilege to introduce him, Dr. Samir Dalwai sir. He is a developmental and behavioral pediatrician who has dedicated his career to develop many innovative concepts and interventions to the children with the autism. He and his team proposed the New Horizon Indian Social Interaction Theory of Autism, as well as the social communication sequence of development. His current work is around the delivering the online intervention programs for the children with a special need. He is the recipient of the Government of India Rajiv Gandhi Manav Seva Award for services to the children in 2012. Founder, director, and consultant at New Horizon Child Developmental Center, Mumbai. I welcome you, sir. Sir is going to talk on ensuring appropriate intervention in children with autism.
Hello.
Over to you, sir.
Hello. I would just like to add one thing for Samir. Samir makes everything very simple, and all the complex subjects he makes very simple. In developmental pediatrics as well as autism, he makes so simple that you start feeling that tomorrow I will become developmental pediatrician. So
yes,
over to you, Samir.
Namaskar. Thank you so much. Namaskar to respected President Sir, Dr. Ramakant Patil Bhai, respected Secretary Amolji, respected our most respected senior, Dr. Uday Bodhankar Sir, respected Chairperson of today, Dr. Anand Bhai Deshpande Ji, Kashmiri Ji, Dr. Jaya, Dr. Sunamne Sahib, all my other co-speakers, all the dignitaries from CIAP, all the dignitaries from Maharashtra, IAP and EB, all my dear friends. Thank you so much for wonderful, kind words. Uday Bodhankar Sir, Ramakant Bhai, Amolji, Kashmiri Ma'am, and of course, Dr. Anand Bhai. The whole idea here is to make our countrymen realize that sometimes we need to wake up and understand that we've been taken for a ride, and things which are actually very simple are sometimes made complicated. And today, the whole topic has been devoted to the theme which Dr. Upendra sir asked me, what could be the theme for this year's IAP Autism Day? And I said the same thing, that we should empower parents via the vital role of the pediatricians. 40,000 Indian Academy of pediatricians are a huge resource to deal with autism. And hence, it's very important to understand that the debate now, if I may say so, with your kind permission, with due respect, the debate is not about what is causing an increase in autism, or whether there's an increase in autism, or whether there's an increase in awareness. That is not the debate, but there are people who want us to be involved in that debate. The real debate should be what is the right treatment being given to these children. And hence, let us not get fooled by what some people want us to keep discussing endlessly. Let us move on to what is happening. And hence, I thank President Sir for taking up the right topic, autism, ensuring appropriate intervention. And that is very, very important. As a disclaimer, Anand Bhai has said just now, all of what I say is not necessarily from Harvard or Yale, because that is not applicable to our country. India's biggest asset in terms of autism is society, family, khandan, kutumba, shezar, pados, neighborhood. And we cannot bypass that. And hence, most of what I present today is not taken from Harvard or any journals. So the disclaimer, it is my experience in the last 20 years, which I shall share with you. It is up to you whether to follow it or not. But all of it is published in Indian Academy of Pediatrics Standard Treatment Guidelines. I thank Dr. Ramesh and Dr. Vinit Bhai for giving me the opportunity to put up our thoughts. And I request all of you, because these talks are 10-15 minutes, please go through these guidelines. There is this new IAP Handbook of Developmental Pediatrics, again on which the chapter on autism has been written, and you will get an idea of what we are saying. Why is there such a seriousness about this topic? Because now the latest estimates show, American CDC shows, that the incidence of autism is up to 3% in the total population. Bharataचं population घेता एक 1.4 billion जर आपण घेतलं, 4.5 ते 5 crore, 4.5 to 5 crore people are there with autism. And if you look at 500 million children with autism in India, look at how much 1.5 crore almost, or more than that, you will find children with autism. This is a huge number. And this is more than probably the population of countries like UK and Australia. And yet we are not being able to monitor what is the intervention being given to these children. Because after 10 years, 15 years of therapies and interventions, these children are still not being able to be normalized. And the disclaimer is said that autism doesn't get normal. I think there is no other medical condition in the world since the last 80 years, because Kanner described autism in 1943. 80 वर्ष झाली, 80 साल हो गए, ऐसी और कोई medical condition नहीं है which hasn't got better except autism. So it is time now to see whether there is any new way we can look at autism. This is data coming from just our centers in Mumbai, and you can see the increasing number of children. And even in India, you are seeing the increasing incidence of autism in India. And I urge all my younger colleagues to start collecting their data and presenting it. This is the data of the age. Can you all see the slides moving? Kashmir?
Yes, sir.
Yeah,
yes,
okay.
Sir.
So this
yes,
is the age at which we were, this data is from 2013-16 at our centers. Children were coming to the center after 6 years of age. The question is, where were they before that? Why were they not identified with the pediatricians? But many pediatricians identify where do they go before they get the treatment. So this is the first child, 2-year-old male child is brought to you. Parents' complaints is not speaking many words. All my colleagues will agree 95% of our patients come with this so-called chief complaint. Parents say he does not follow instructions, but he can recite alphabets, number names, badbad gani, nursery rhymes, etc. And there are no hand flapping, spinning, म्हणजे आपल्याला typical जे autistic जसं वाटतं, there are no such features like that. What is my request to our dear pediatricians who are going to treat this? Clinical approach should be first in this child, always do a hearing evaluation for every child with a speech problem. There is a clinical evaluation which I will talk about. Just make sure you check the other domains. Check whether the motor domain is all right. Check whether there is any hepatosplenomegaly. Check whether there is any neurological deficit that is being seen. Check for hydrocephalus. Check for macrocephaly, etc. And finally, because this child has come at this age, don't hesitate. Rather, always do an M-chat, which we will come to later. The red flags that we must notice for children with this problem is no big smiles or joyful expressions by 6 months of age. No consistent response. हाक मारल्यावर आप जब आवाज देंगे बच्चा ध्यान नहीं देता है. Parents will tell you नहीं डॉक्टर उसका मूड है तब ध्यान देगा. There is no mood disorder in 2-year-old children. It is basically inconsistency in responding or recognizing that the child is being called by the mother and hence looking at the mother. By 12 months, these children do not gesture, do not point, do not make simple symbols, do not wave, do not point out things. And even by 15 to 16 months, there is no single words. New Horizons had conceptualized this entire idea. Last 10 years we have been talking. It is not about saying a word, not just saying Baba or Mama or I. It is about understanding that the child is looking at the mother, wants to address the mother, संबोधित करना चाहता है, आणि त्याच्यानंतर काहीतरी काम आहे म्हणून संवाद साधतोय. Is calling her out for some purpose. That is very important. That is a true milestone. Just saying Mama, Baba repeatedly does not mean it's a normal, meaningful word. And finally, to make things more interesting, what is the SRK sign of development? I'm sure you all know SRK stands for Shah Rukh Khan. And this is the Shah Rukh Khan sign of normal development. Because when Shah Rukh Khan does this, the heroine automatically figures out that she has to run into his arms for an embrace. And this is what exactly is called in American jargon as reciprocal social interaction. Keep all those words away. Simple ahe. Aine asa hath kila. If the father does this, the child does not understand that he has to run into the father's arms or the mother's arms. He will not focus on the mother or father and will not show this emotional reciprocity to run into the arms for an embrace. So along with this, does not play with toys appropriately, keeps only playing with the wheels of the car or opening and shutting the door, lines up objects instead of using them meaningfully like other children would. He has some odd movement patterns like toe walking, or has repetitive behaviors like hand flapping or waving or spinning. And of course, if the child has regressed and lost any milestones. Very important to understand, all of you after this talk, please go online and in Google or whatever, type mchat online free. When you type this, you will get a website called Autism Speaks. On that, you will get question 1, question 2, question 3. You answer question 1, automatically it goes to question 2, then question 3, question 20. It automatically gives you a score. You don't have to remember. We understand it is low risk, medium risk, or high risk. You can print it out and you can charge the patient. Do that, charge the patient, but do the mchat, because that is going to be very, very important for you to assess the risk at an age below 3 years of life. What do you understand by this child? This child had an impairment in social behavior. So like Dr. Amdekar tells us, write down clinical observations and clinical diagnosis. This child has an impairment in social behavior, impairment in communication. As you saw, both non-verbal as well as verbal were absent. And hence the diagnosis here is social communication disorder. It's not very difficult. What is important is, what do you do after this? Very often we end up referring this child for various therapies and the child never ever follows up with us and is lost to follow up. What we need to do as a pediatrician is stop that and first counsel parents, tell them what do we need to do and then monitor the child. So what will you tell the parents what to do? Every child, like we mentioned, has to have a hearing evaluation. Second point is stop screens. It is screens which are worsening the child's focus away from parents. And hence screens have to be stopped. Various people have published studies about the eyes being damaged and the retina being damaged and hyperactivity being caused. I have a completely different theory. My theory is calls autism as ati vastu magnata and kami manushya magnata. It is excess involvement towards objects that causes autism, and screen is the worst object, or mobile smartphone is the worst object. Instead of allowing the child to interact with screens, keep the screens away and interact with the child yourself. And that is the theory of social interaction of New Horizons that Dr. Kashmiri was speaking about. And interact with the child all day, keep the child to focus on you. Masti kara, khela techa borobar, tickle the child, hug the child, kiss the child. At every cost, draw the child's attention towards yourself. Don't focus on teaching ABCD 1, 2, 3, 4. Good morning bolo, good evening bolo, or ABCD bolo 1, 2, 3, 4 bolo. Because these children are pattern learners, they will copy some patterns and they will repeat it. That is not an improvement of autism. That is a complication of autism called echolalia. So beware. If somebody comes and says that we have done some improvement and treatment and now the child is repeating words, beware. It is not an improvement. It is a complication. Hence, be very careful not to just make blind references. Anytime you see the child has a speech problem or a behavioral problem, don't just start referring here and there. You manage this child yourself by giving this advice to parents. Very important, call the child back, monitor after a month, ask the questions. Has the child stopped watching screens? Does he look out more for the parents? Does he interact more with the parents? Does he want to be around parents more? Looks less lost in his own world? Does less of repetitive activities? So my pediatrician friends ask me, Samir, how can we monitor? We are not therapists or we are not experts. You don't need to. You need to be an expert in child development, normal development. See whether the normal development is coming back. And gradually the child will then start understanding speech. If this doesn't work out for a long time, then of course you can refer. And hence, if you look at some of the references that I've put up, our theory talks about the fact that these aspects are not separate. It is basically the impairment in social interaction that leads to a consequential impairment in social communication sequence, and hence focus first on human interaction. A 4-year-old child is brought to you for hyperactivity and aggressive behavior. He does not sit in his seat in class. Parents say he says some words repeatedly. As compared to the previous child, he likes to flap his hands, jump up and down, or spin around when excited or angry. And this is a video that I'm going to play here. He's not looking at me, he's looking at the camera. Look at what these repetitive movements he is doing. These repetitive movements don't signify any neurological problem. The most important aspect here is he has zero attention towards his mother who's sitting behind him. Don't get carried away by these repetitive movements are not epileptic seizures, mind you, that you need to get scared and send them away. They are just behaviors because the child is not focusing on parents. Please understand that. Don't get scared by what the textbook tells us. And hence, this child also had an impaired behavior, a social interaction, impaired communication. Hence, it was a social communication disorder. Plus, he has these repetitive behaviors, restricted interest, and the diagnosis will be autism spectrum disorder. Now, what will you do in this child? Again, hearing evaluation, stop screens, interact with the child for all children. But in this case, also divert him away from repetitive activities. You don't need any specific therapy for repetitive activities. Please remember and keep the preferred objects away. People will tell you, oh, he likes to play with that particular toy. This is the toy that you have to begin with. First use this toy, then you bring his attention towards yourself. It does not work. He will keep involved only in the object. Don't focus on teaching activities, speech or academics, because that is sure to worsen his object involvement and pattern learning. He has to focus on you and not the objects. Again, what will you do? Call the child for follow-up every few days. Look at whether he's ignoring screens, look out for parents and interacts, less loss in his own world, does less of repetitive activities over a small period of time, and gradually starts understanding speech. And hence, all this can be done by you, advised by you, monitored by you as pediatricians. Do not just make blind references here, there to anybody unless you have tried this with the child and parents yourself first. If all of that doesn't work in 1 month, 2 months, 3 months, then sure enough, you will refer and we'll talk about where to refer. This is an older girl brought to you. Parent says that now she says some words, but not quite a lot like the other 5-year-old children. And that too, it has developed after they had gone to speech therapy for about 2 years. She is not hyperactive now. In fact, she sits in her seat in a corner quietly and is happy not to be disturbed or involved in any class activity. So in fact, the teacher is very happy. No problem, no taklif to the teacher or anybody else. She used to have some repetitive behavior earlier when we asked them for history. But again, with some therapy, that repetitive behavior has gone down. She is in fact good at copying alphabets, words and numbers. So fortunately, she does not need a shadow teacher. But the parents are worried that there is something not quite normal about her. She can't go and stay with her aunt for 2 days. She is not able to go to the neighborhood and interact with people. So again, when we do the clinical evaluation, if you go through it, this is a child with impaired social interaction, impaired social behavior, impaired nonverbal and verbal communication with some repetitive movements earlier, which were physical repetitive movements. They have been replaced by repetitive academic movements. Writing ABCD is a pattern. It is a repetitive repetitive activity, like that boy you saw who was swinging or he was rocking. Writing ABCD in a pattern is also a repetitive activity. Don't make a mistake of thinking this child has improved. Her social interaction, social behavior continues to be very bad. She continues to be aloof. Sometime later, she'll start showing signs of anxiety because she has no understanding of how to connect with her classmates. And you will keep thinking, oh, wonderful, this is working. Let's continue doing more and more therapy. And that is not going to help the child. So again, in this child, hearing evaluation, stop screens, interact with the child. What this child needs at 5 years is involve with kaka, kaki, mama, mami, maushi, atya, and don't focus on teaching activities or academics, which is very difficult to convince the parents because they say she's doing very well academically. If she continues to do very well, it's not very well. She's just pattern learning and she will continue to get worse at how to behave in society. How will you monitor this child? Call the child back to your OPD, ignore screens or no, interacts better with now relatives also, looks less lost in her own world, gradually see that her social understanding and behavior with peers and her classmates is getting better. This is what you will monitor. Of course, if you need further help, you will refer her. This is now 2 cases I will show. 10-year-old boy diagnosed already with autism at 3 years in the United States because the parents had gone there at that time. He is brought to you. This is a real, all these patients are real, and this is a reality for all of us. He has received intense speech therapy, then occupational therapy, remedial education for some time, counseling, left, right, and center, ABA, art-based therapy earlier. Now he's going for music therapy. Some agency, father told me, has contacted them for color therapy, flower therapy, animal therapy, stem cell therapy, and magic therapy. And in fact, all of them should be called magic therapies only, because there is no science to any of them. But it's doing very well in practice because all of them want to go and do all this. And pediatricians say, we don't know anyway, मेरे को कुछ नहीं आता इसके बारे में, तू जा. ऐसा नहीं है, हमको बहुत कुछ आता है. We just need to start doing it. He is good academically, again, writing ABCD, 1, 2, 3, 4, by hearting Shakespeare, but parents feel he lacks social manners and has some defiant behaviors. So he cannot be taken out to social gatherings. He cannot be left alone with anybody else. Parents have to sit in the classroom and see that he is academically involved. This is clinical evaluation, you will say, is autism with multiple therapies and poor outcome. Don't make a mistake. Because he can by heart Shakespeare is not an improvement. That was an outcome of his original problem where he was very good at repetitive activities. Don't make a mistake of thinking this is an improvement. This child is now going to have a very difficult time. And then you will see 5 years later, when he becomes 15-year-old, similarly another boy, somebody said autism, somebody said intellectual disability with ADHD, without ADHD. And that's why I said in the beginning, the diagnosis and the awareness doesn't matter. Look at what happened to him. He still has poor speech, is hyperactive, aggressive, violent, has little dysmorphic features, does not follow parents and teachers' commands, insists on doing his own activities, cannot be taken to gatherings, relatives or neighbors' homes. He was given multiple therapies in the past, like the previous child, plus methylphenidate, clonidine. Many people are fond of giving clonidine and risperidone in the past, and yet this is the outcome at 5 years. मला parents विचारत होते हैं कि डॉक्टर आम्ही 10 वर्ष 10 साल आपने जो बताया या जो भी हमको डॉक्टरों ने बताया, हम सब टाइप के थेरेपी, सब टाइप ऑफ स्टेम सेल करो, ये करो, वो करो, सब किया, अभी ये ऐसा क्यों है? तो उनको मैं पूछता हूँ, आप जाके पूछो जिसने ये सब किया उनको कि ऐसा क्यों है? अरे वो बोलते वो तो ऑटिज्म है, इतना नॉर्मल तो होगा ही नहीं. This is the point. Why should something not become normal after 80 years? If it is not becoming normal after 8 years, then what we are doing obviously is wrong. At least look at that and change that. Because we can't keep waiting and doing the same thing and writing poems on autism with A capital for something, B capital for something, or wearing blue color or wearing purple color or green color is not going to change typhoid or TB or malaria. 100 years back, 200 years back, we thought measles was also caused by some curse of somebody. Devi वगैरे म्हणायचो आपण त्याला. Today we have vaccines and medication for it, and it has disappeared. Not because we prayed more, but because we realized science more. And today we are at the same stage of autism what we were in measles 100 years back. And we need to understand that this is an adolescent ASD with multiple diagnoses, concerns, interventions, and definitely poorly managed. So don't make this mistake. What do you need to do? In these cases, the message is what not to do. Don't just refer for these blind referrals and okay, ABA chal raha hai, chalne do. You have to monitor what is happening with the child. So what you need to monitor again is whether the child has reduced his screens, interacts better with parents and relatives, looks less lost, is more adaptive, less aggressive, less anxious. He may need medications at this age because he's already developed severe patterns. You need to explain the parents, don't focus on teaching activities, shape sorting, envelope making, candle making. अरे candle making से करने का क्या? कितना candle बनाएगा इंडिया में? कितना envelope बनाएगा? Everybody wants to make these children do only envelopes and candles. Not needed. They can become normal. And hence, gradually the child will improve his social understanding and behavior with peers. And hence, in this case, check where you had referred. Ask them, ki, bhai, after 10 years, why is the child still like this? So the question is, are we giving the right advice? Referring to this service and that service is like Asrani in Sholay. आधे right में जाओ, आधे left में जाओ, बाकी मेरे पीछे आओ. आपके पीछे कोई बचेगा नहीं आने के लिए. Because all of them have gone where you only send them. It is not necessary just to send them. It is important to check the quality of intervention that they are getting and monitoring the child and following it up. And hence in adolescence, the parents are most worried about the future, not because of education, but now they've realized the bigger problem always was social behavior, which was ignored. Medications may help to some extent. And finally, last case, 2.5-year-old female child brought to you for not speaking many words. She was all right earlier. She had started recognizing parents and family in the first 1 year of life, calling out to her mother normally, showing interest in sharing things. After her first birthday, parents noticed she really started regressing, lost interest in them, stopped saying anything, rather lost looking at her own hands and moving them in a particular manner. And I'm sure all of you must have guessed that clinically, this is a child of autism with true regression, with MECP2 missense mutation. And my friend, Dr. Leena Srivastava, has written a very good chapter in the IP handbook on reds. Please look it up. In this child, what do you need to do? You need to do the same things again clinically. Please don't say, "Ye to genetic case hai bhaiya." Arey, everything is a genetic case. All the earlier cases also had a genetic problem. That's why that was a clinical picture. Don't refer them away. This is all on the left side that you can see on your screen. All the things that you as a pediatrician can do. Of course, you can need to refer this child to a geneticist also, but monitor the child's clinical improvement, sir. This is what you can advise the parents, and you can tell them not to focus on teaching activities, speech or academics, but to focus on human interaction. And this is what is going to save all these children and make them far more normal than just repetitive therapies. I'm sure as pediatricians, all of you are very good at all these evaluations, especially for dysmorphology. Investigations, again, there is a huge misconception. There are some people who send every child for MRI, EEG, not required. What is required for all children is perhaps CBC, thyroid function. Only if there is dysmorphic features or if there is a family history, you need to do a genetic evaluations. If there is any history of seizures or absence or sudden abnormal behaviors or sudden laughter spells, perhaps an EEG, an MRI brain, if there are seizures, any neurocutaneous markers and any signs of seizures, as I mentioned, and any focal neurological deficit. But in the male child, what Dr. Rashid Merchant, who we have been fortunate to learn with, has taught me, and in fact, in New Horizons, we have about 4 or 5 children now with DMD and autism. So CPK is a common gene that we have seen. And of course, fragile X if it is a male child. And if it is a female child, you would be advised to do a MECP2. This is again from the standard treatment guidelines. So you will use MChat to screen all children between 16 and 30 months of age. It's available online. You can download it just now and do it in your OPD whenever you want. Your assistant can do it. Don't forget to refer these children for a good vision and definitely a hearing evaluation. All these evaluations confuse us. Baba, ye mala samjhat nahi. Abhi isko kisko ISA, IDOS, ADIA, ye kisko samajhta hai? Question is, जिसको समझता है और जो करके देता है, उसको पूछो इसका फायदा क्या है? How did it help? Now you have a report. Now tell me how are you going to treat this child? Now tell me in 2 months what improvement you expect in this child. In 4 months what treatment you expect in this child. This is important. Looking at comorbidities, there are 2 types of comorbidities here. Don't worry too much about the right-sided ones, but look at the ones on the left. I promise you, my knowledge of nutrition is definitely lesser than yours. My knowledge of allergies is definitely lesser than yours. So you have to handle the overnutrition or undernutrition, the dental problems, the allergies, the constipation, sleep disturbances. And that's why I requested Dr. Sunavne to talk about how to identify these problems in a child with autism. Management, we know that we can use methylphenidate. These are the drugs, at least, which I use, risperidone, fluoxetine. This is all there in the standard treatment guideline. 2 things which we need to use very importantly, or one thing is basically train the parents to use a schedule. None of my children at my center, maybe even only 2% have been put on melatonin. 98% of them improve their sleep disturbances if we counsel the parents correctly. And even for constipation, only if we counsel the parents correctly. It doesn't require medicines, but you can start with medicines to soften the stool. Myths, finally, is please tell your patients it is not a speech disorder. Treating speech or working on speech is not going to solve the problem. It is not a learning disability, not due to father speaking late or multiple languages at home. It is not due to lack of exposure during COVID as people think, though it must have worsened it because COVID also is associated with excessive screen exposure. These 2 worsen autism, don't cause it. So of course you have to expose the child to humans and cut off screens, which is what I'm saying for the last 20 minutes. These myths are very important that pediatricians cannot manage developmental behavioral concerns. And let me say this because ये अपने घर का platform है. There have been many experts who have come and given you talks. Oh, once you screen and it is MChat, refer to XYZ, ABC, XYZ, so-and-so person. No, it's a misconception. You have been fooled. You can manage developmental behavioral concerns. Speaking with parents may seem difficult and time consuming, but it is not. Pediatricians should not be able to follow. Of course, you can follow up normal development of the child. Everything has to be referred to whoever is available. Kidhar bhi, kuch to karo, bechare bachche ko kidhar to bhejo. That is not true. Don't think that this does not have a side effect. If you keep giving paracetamol for fever for 2 days is okay. Who has given paracetamol for 15 days for fever without doing anything else? That is wrong. Are nahi kaitari amma tala paracetamol is there. Do we do like that? No. So please understand, whoever has told you about early intervention, early intervention, early intervention. That is rubbish. What is important is early correct intervention. Just early intervention tells the patient to go into a particular destination or a particular service and doesn't give any responsibility to the service provider to give a good result. It is your responsibility for referring early, but it is my responsibility to give the correct intervention and not just keep giving you lectures on how to identify children early and send them to me. So this is how you will do the correct intervention in your clinic. This is again from the STG, just to tell you, unless you assess the comorbidities and differential diagnosis, you cannot come with a good outcome. That is again the pediatrician's job. Second thing, don't give symptomatic treatment. Delayed speech hai to uska treatment, hyperactivity hai to uska treatment, aggression hai to uska treatment. It doesn't work like that. All these are symptoms. You need a diagnosis, and hence intervention has to have a larger component of home and community-based interventions rather than clinic-based interventions. This is what we are practicing at New Horizons. Treatment program should be monitored at our center. The development pediatrician monitors the program every month to ensure appropriate response to therapy, and the program should be reviewed. I have seen children who are getting the same intervention for the last 2 years. There is no change. How do you expect the child to change? If there is no improvement in 1 or 2 months, you need to change your tactics. But you can't keep doing the same thing and having the same result. There is no role of vaccines. There is no specific role of gluten-free or casein-free unless the child has celiac disease or gluten sensitivity. There is no role of hyperbaric oxygen, stem cell, etc., which has been banned. And hence, remember, non-goal-oriented, arbitrary, unending, repetitive, symptom-based intervention should not be advised because they are not going to help the child. But with appropriate intervention, most children, especially mild to moderate, will be steered towards normalcy and meaningful social interaction. And though early intervention is a buzzword, equally important to have the correct, appropriate, dynamic intervention. And you need to monitor whether the child is improving or worsening. So take-home messages, you are the cornerstone of developmental behavioral pediatrics, not me. Simple concepts need to be picked up and implemented. What we explained today, you can go to the STG and look it up. Documentation helps us learn better. Speaking with parents is the same as in any other conditions like chronic cardiac disease or chronic nephrology conditions. You need to get involved with the child. And if you get involved with the child and family, we are going to be able to tackle this 3% incidence of autism in India. Thank you very much.
Thank you, sir.
Well done.
It was really a wonderful session. Actually, sir has likely said, whenever the patient comes to us, always mother says that तो 1 2 3 4 छान बोलतो, तो ABCD छान बोलतो, तो rhymes खूप छान म्हणतो. पण जर तिला विचारलं तुला आई म्हणतो का ग, तर answer is no for that. So this is a very practical session. Sir has taken lots of myths, lots of confusion regarding the speech therapy. I mean, he has cleared all the misconceptions and he has cleared the autism in a very simple way. Thank you, sir. Thank you once again. So there is one question for you. There is a role of DHA or omega-3.
There is no scientific evidence to prove the role of DHA or omega-3 because autism is not proved to be caused by a deficiency of DHA or omega-3. There is no, if there is a deficiency of insulin, you will get the diabetes. A deficiency of thyroxine will cause hypothyroidism. There is no deficiency of DHA in the body or to give DHA and expect a result. No scientific studies have proven that. Thank you.
Is there any role of milk curtailing?
Again, that is yeah. So gluten-free and casein-free diet has been recommended, but casein will cause a problem in somebody who has an allergy to casein. Gluten will cause a problem in somebody who has an allergy to gluten. He need not be autistic for that. Anybody can have a gluten sensitivity, casein sensitivity, like lactose intolerance. So if you feel he has an allergy, test it and only then restrict it. Thank you.
Jaya Shivakar madam wants to share something. Ma'am, please. Ma'am, unmute yourself. Ma'am.
I need to share the slide, no?
Yeah. After question answer.
Bodhankar sir.
Yeah. Good evening, Rashmi. Samir, as usual, salute to you for clearing many doubts. Number one, sometime when we ask them about hearing evaluation, there is a resistance from the parent that he hears they thing, you have to correct whether it is a mandatory, number one, to have evaluation, because I try to convince them, many times they are not. So then we label it as a ADHD query, mild ADHD, and then we refer. Number one. Number two, any role of alternative therapy, like I was going to the literature. Some say some homeopath, some say Ayurvedic something therapy. There are two things I would like to know.
So the first question was on ADHD, did you say?
Is it mandatory to undergo hearing evaluation every child?
So mandatory to hear
Okay.
to have a,
Done.
that's close. The second part, there is no role of any other substitute or substrate, because the body does not lack unless it is associated with IEM, which is a very, very rare condition. So there is no role of anything. At New Horizons, it is our work. So I'm not claiming credit for it because it has not been published in Harvard and Yale. But what we have realized, our work shows it is a deficiency of interacting with humans that causes this problem. And in today's world, the world is full of objects. आम्ही कोकणातले असल्यामुळे सांगू शकतो की आम्ही कोकणात एक शब्द आहे माणूस घाण. तुम्हाला मराठीत म्हणून मला बोलावं लागतंय की माणूस घाण. People, this is a 2000-year-old gene. These are 2000. These people were earlier called people who are not very social, but they are very good in numbers, patterns, music, accounts, etc. This has worsened because of society today. And this is what is our theory of autism. And we need to reverse this. If you reverse this, we will publish our report soon. Most children will do well. Thank you.
How common it is in the joint family? Autism.
Sorry, even in joint family, everybody is jointly looking at their devices. So nobody is sitting face to face in a joint family or in a circle. Everybody is sitting sideways. So everybody is like this. So there is no interaction happening between people. So it is the same in joint families. Even in small families, if the child and mother are interacting all the time, you won't get that. In a joint family, everybody is on mobile, you will get it.
One more question.
Yes,
is there any genetic or metabolic cause?
I have a bigger nose because it is a genetic problem, and I have everything about you is genetic. So the genetics in all of this is autism has genetics. My suggestion to whoever has the money to do the genetic test is don't look for speech delay in a gene. Don't look for hyperactivity in a gene. Look for a gene which codes for human engagement. I don't have the money. I'm a clinical practitioner. If somebody is in a genetic lab in US, Harvard, UK, and listening to this, look for a gene which codes for human interaction. And that will be the key.
Last question, Samir. Any role of stem cell therapy?
They should be in jail. Anybody who says that, who takes money for stem cell therapy should be in jail. I don't know who, so I can't take any names because nowadays is the season of defamation cases. So I can't take anybody's name, but I don't think there is a rule.
Thank you.
Let's move to the next.
Thank you, sir.
You are running late.
Thank you. Sir is going for a next meeting, so he may take a leave from this meet. Thank you, sir.
Thank you
once
very
again.
much. My gratitude to all of you. My
Thank
gratitude to all of
you,
you.
sir.
Thank you.
Salute.
Now I would like to invite our next eminent speaker, Dr. Jayashree Shivalkar, madam. She's a developmental pediatrician and child adolescent psychologist. She has a special interest in autism, child development and activity center. And she's also a member of State Advisory Board on Disability, Maharashtra State. She's the ex-president, Adolescent Health Academy, Nagpur, conducted various workshops for the parents, teachers, students, rehabilitation professionals. And she is also a member of State Commitmental Health Board. So I welcome you, ma'am. Ma'am is going to talk on ensuring health, nutrition, hygiene, and vaccination in children with autism. Over to you, ma'am.
Yeah. First of all, good evening all, and thank you so much for having me here. And not only that, the topics are such which are very dear to me, and this is something I wanted to convey to pediatricians for many days. So thank you for this topic. And the topic is ensuring health, hygiene, nutrition, vaccination in children with autism. Next. What Samir sir has actually emphasized here is that next slide please. We pediatricians need to take care of children with autism. We want to break that routine which is formed as if the diagnosis is autism, refer to OT. If diagnosis is autism, refer to speech therapist. And you will see that the child will never come back to you. So we want to break this myth, and we want pediatricians to empower themselves to handle these issues. Now, apart from the intervention, which Dr. Samir has talked, or whatever behavior and developmental therapy we all talk about, we want to see, we want to make sure, we want to ensure that pediatricians are taking good care of autistic children in their routine OPD for their routine problems. So what we are targeting here, or what we are emphasizing here, ensure that a child with autism is a child first. So he is going to have all the problems which a normal child would be having, or all the infections or whatever trauma which we are seeing in a normal child. This child is also going to have this. So health is a basic right of this child, with autism, without autism. But as a pediatrician, we must be aware of the challenges when we are handling the child with autism, as well as we have to understand the barriers which we are going to face while examining, while advising treatment, while taking history and everything. So that is what we are going to see in this session today. Next, please. So there are certain special considerations we need to keep in mind whenever we have a child with autism. And the first most important thing is that child has limited capacity to express, either non-verbally, or he has a very limited verbal expression. And we are so used to verbal communication. The children will tell, yahan dukh raha hai, ithe dukhta hai, tithe dukhta hai, payala lagla hai, doka dukhta hai. And child will express in his own language to his mother first. But here, a child cannot express. So it is so difficult for a parent to know what is happening to a child. Already, a child has some non-specific gestures, hand movements, hand flapping movements. Hence, many times the exact pointing may also be missed. For example, ear pain, stomach aches. So many times we have parents coming to us and they say, my child is crying for 2-3 days. समजूनच नाही राहिलं काय झालंय ह्याला. Because the child is not able to express, he is not able to point out, he is not able to understand. It may be nasal block, it may be ear pain, it may be some insect bite or stomach ache. So this is the first barrier we need to understand whenever we are dealing with child with autism. Next, please. The other important point which we need to remember is that many times these children have less pain sensitivity. So it can be very misleading as trauma, injuries or bruises. Many times parent will come and tell you कि 2 दिन बाद समझा कि इसको पैर पे लगा हुआ है. So child will not come and tell that I have this problem, that my pain is, my leg is paining, or I have fallen and there is a bruise or something like that. So again, this is one very important point a pediatrician need to understand. Child may not understand or follow instructions, especially in older children and adolescents. So it is again a very routine for us to tell कि 2 बार ये medicine दे देना या 3 बार ये medicine दे देना. Sometimes we tell the child कि बाहर का नहीं खाना है, आइसक्रीम नहीं खाना है, या टीवी नहीं देखना है ज्यादा. So routinely we are so verbal and so verbally communicative that we fail to understand that this simple instruction may not reach to the child. So you may tell the child and then parent will say उसको कुछ समझा ही नहीं है. Child doesn't follow those instructions. So this also we have to understand. We have to first understand how to communicate with the child, or maybe how a parent would convey the instructions to the parents, to the child. And the most important is child may not be cooperative for examination, because these are children who have high sensory zones. So, you know, the AC in the room, or maybe some smell, room freshener in the room, consulting chamber, the other smell, the different environment, all this can put off the child. He may be uncooperative, he may not respond to the routine thing, like we say ki yahan so jao, remove your clothes, whatever simple instructions we give, these children may not be so cooperative. So we have to be little more patient, or we have to take help of a parent to make the child comfortable, and then we have to examine the child. And we also need to remember that we may not get the complete history, what is happening to child exactly. Next, please. Another point which is very important is that again we are so used to give medicine as per our normal practice. Syrup hai, tablet hai, multivitamins hai, but here the main is that the child may have difficulty in taking medicines. It may be because of the taste of medicine, it could be because of the color of the medicine, it is because of the texture of medicine or smell of medicine. And we all know that many syrups do have typical smell or typical taste, which is not a very palatable thing. So it is very difficult for parent to give medicines. So many times for the first 1 or 2 days, they just forcefully give the medicine, and many times even the antibiotic dose which we recommend is not given completely. So this we have to ensure what type of medicine we are giving, and we just don't stop by writing on the prescription pad, but we have to ask the parent, will the child take this, or do I need to give dispersible tablet, which is the better option. We have to emphasize that if it is a course of 3 days, 4 days, we have to give it regularly. So a bit of counseling or a bit of special instruction need to be given to the parent also. Then we have to be careful about the overdose or accidental ingestion also. And this is very common because the child may just take it. If he likes the smell, if he likes the taste, he might overdo it. So this instruction also we have to give when we are dealing with the child with autism. Many times the parent is working parent, or the child might go to school. So it is the responsibility of a caretaker or a grandparent which need to be guided properly. So we have to tell the parent that you have to convey the same instruction to the caretaker. Agar caretaker bai hai and the child is not taking medicine, might be she will not give only. नहीं ले रहा है तो नहीं ले रहा है, and the child will miss the dose. So these are the things which commonly happen in case of children with autism. And as a clinician, we need to keep this in mind, especially when we are dealing with these children. Next. At the same time, we must be aware that child may already be on some other medication. So we need to ask, maybe for hyperactivity or maybe for seizures, the child is already having any medication. So that care we must take. We must ask कि ये और कोई medicine ले रहा है कि नहीं ले रहा है. We have to be aware of associated nutritional deficiencies. Why these nutritional deficiencies are there, we'll see in the next slide. The third important point, which is very important, is many times these children have limited water intake because they don't ask for water, because they don't respond to these needs as a thirst or hunger may also happen. Maybe water is not accessible and the child is not asking for it. Maybe just child is engaged in himself and he's not aware that I have to drink water. He's not cooperative when the mother is giving to water. But this is very important complaint given many times to me by parent ki madam ye pani pita nahi hai. And whenever you are giving medication or antibiotic, we have to make sure that child is getting enough water. So emphasize with the parent that he has to get enough water so that he's passing clear white urine, not the yellow color urine. So that instruction also we need to give. And associated epilepsy, anxiety, depression, if it is there, we have to consider that also while counseling the parents. Next. Next, please. Yeah. So why these children frequently are ill, or they may have some problems which are quite common? It is because they have challenges in hygiene. We have our module, which is very good module of NCECD, where we are considering all these things: hygiene, nutrition, health, early learning in normal children. And day by day, we are realizing the importance that if we give this normal hygiene, health, and nutrition, the children will be developing nicely. But in case of these children, there are many challenges in hygiene. Most important are lack of skills for personal care. You just ask about toilet training and the parents will tell you n number of problems. ये बच्चा टॉयलेट में टॉयलेट की जगह पे जाना पसंद नहीं करता है. He doesn't like the smell there. He doesn't like the confined room of toilet because it's a small room. So he will stand somewhere outside and then he will pass the motion. He will not like to touch his own body parts to wash. Or sometimes they may have bad habits that they handle their private parts even during toileting. So there are many problems in hygiene. So we have to make sure that maybe we can take some separate session for the parents, or maybe some instructions you can give to your staff also. So lack of skills for personal care makes them prone for infections. Then they are mostly dependent on caretaker for their cleanliness. And if the caretaker is not very efficient, naturally these children will have lot of skin related issues. And actually we are seeing this, and not only in children, but many adolescents with autism have lot of problems related with their skin hygiene. So this needs to be emphasized. Then they have sensory issues like with touch, texture, smell. So somebody may not like to use soap, somebody may not like to use body brush, or problems in dental care because they just don't want to put that brush in their mouth. Many autistic children will take the brush and they will just chew it. They will not brush their teeth. They will chew it and throw it. Many cannot, gargle properly. So lot of issues are there in the personal care. So brushing, clothing, sometimes they want to use the same clothes without washing. They don't use properly napkin or handkerchief. Their hair care, hair washing, hair drying, and hair cutting. These are all problems for parents because they don't go to that salon and they don't cut their hair properly. They don't like hair wash. So a lot of problems in hygiene are seen. Similarly, if you ask the parent कि आप इसके nails cut करते हैं क्या, तो parents will say हम रात में करते हैं when the child is sleeping. Why? Because child will not allow the parent to cut the nails with nail cutter. They'll just refuse. So problems with the nails, eyes, ears, oral care, these all problems are very, very, very commonly seen in children with autism. And as a pediatrician, regular pediatrician, we need to be aware of this, and we need to emphasize this to parents what challenges they have to face. So a lot of skincare, sweating, and pimples, especially in adolescents. Very, very, very bad skin care in the area of groin or in the genitals. Because they are 15, 16-year-old, parents are not going to bath them daily. Neither they are going to check it every day, their genital parts. So here also we have to tell the caretaker for proper training in cleaning themselves, especially the undergarments and groin area. Next, please. So similarly, as we all have seen in pandemic, hand washing is very important, and it's a very routine thing which we are doing, but very challenging for parents. So we have to emphasize hand washing before and after eating, and even after toileting. So many children are missing this hand washing after toileting. So when they use toilet in the school, or when they use toilet when mother is not at home, they just skip this hand washing part of it. They'll just wear their clothes and go and start playing. So this needs to be emphasized, hand washing. Another thing which is problematic is mouthing of objects. Even up to 10 years, 12 years, 14 years, these children have tendency to put things in mouth. And that of course can lead to so many things. Even lead poisoning can be because of this, but common infections and worms are very common. Then they are prone for self-injury and scratches. Many times we see children with autism, if they get a boil or if they get some bruise, they will keep on scratching it. So the wound will not heal. Why? Because the child is continuously scratching it. So here again, we have to use some device or we have to train the child not to do that. And toilet training definitely is a big issue. And we have already discussed the problems related with toilet training. Next. There's some special concerns which pediatricians need to be aware of. That's the sleep schedule is a problem. Now we are very much concerned about sleep schedule, even in normal children and adolescents, because we are seeing problems because of lack of sleep schedule. So here, sleep schedule is very important. Counseling for that is very important. If there are associated syndromic pattern, Dr. Samir Dalwai sir has already discussed this, Fragile X or tuberous sclerosis, and the comorbidities, ADHD, intellectual disability, allergies, or behavioral issues. So these are also something which a pediatrician need to keep in mind. Next, please. So next come the nutrition. We all know the importance of nutrition in growing children. So I will not go in details of that, but coming to the practical problems which these children have, especially in autism. So one of the important problems is that they are picky eaters, very bad eaters. They don't try new things. And since childhood, many times the parents are giving them the same thing again and again, because the child becomes hyper when the thing food item is changed. So they are very picky eaters. Pica is very common. So all the problems associated with pica we can see in these children. They have food fads. Some may have a very milk-based diet. Sometimes they are so used to giving soft food that many times parent just mash chapati or rice in dal, and the child is just swallowing it. So chewing part is hardly there. So we have to emphasize this part, that child needs to chew the food. And chewing also helps in developing speech because of the exercise of oral muscle. So continuous soft diet is not recommended. Continuous hard and dry diet is also not recommended, which is also very commonly seen. What these children do, the mother will apply some ghee to roti, make a roll, and this child will eat. So even that is not recommended. Crunchy texture issues are there, but we have to give variety of texture. In fact, this is one of the part of therapy. And then for diet, they are dependent on caretaker. The caretaker is not very much concerned about it. She will keep on giving the same food over and over again, and let the child be in a very comfort zone in reference to eating. Here, child will then not try different food and will land up in deficiencies. And of course, screen addiction. We have seen junk food habits and screen addiction as they are seen in normal children. It is seen in these children also. So high sodium and high carb diet is very dangerous, and it leads to a lot of nutritional problems, as we all know. So here also we have to take care and warn about the junk food habits. Next, please. The problems because of all these issues which we see are that child may have constipation. Constipation is because of many things. The first important thing that they don't like the process of toileting. They don't want to enter the toilet. They don't want to be in that smelly area. Sometimes they will go, or they are used to use the toilet which they have at their home, which might be very clean and neat. But they will avoid going to toilet if they are in the school or if they are on the travel or somebody else's house. So another toilet is not tolerated. So they will have constipation and all the problems related with constipation, like injury to anus and all those things. Nutritional deficiencies are very common, as we have seen, because of their eating issues. Similarly, malnutrition can be seen, but as they grow, they get used to screen as well as to junk food, and many autistic children are obese adolescent. So that also we have to take care. And instead of being attracted to food, they may have food aversion, leading to severe behavioral challenges. Then it becomes very difficult for parents to handle this. And some food allergies. Specific diet, as we have already discussed, they don't have any specific role unless there is a proved allergy. So gluten-free or casein-free are not recommended from our side. Next, please. So just a word about vaccination. Vaccination, as I already told you, this is a child first. So whatever vaccination is recommended for all children, it is recommended for these children also. No different in any other vaccine. But problem is we need to follow, because many may miss out the vaccines because of the therapies or the myths associated with vaccines. As we all know, MMR vaccine and autism has been repeatedly blamed, which is not true. But some parents may read on the net and they will avoid vaccination. Sometimes they are misguided by other therapies or alternate pathies. Don't give vaccines. So it is very important for pediatrician to keep a regular follow-up of vaccination, because child with autism must get all the vaccinations. Many times these children lose track with pediatrician, and that is why actually we all are here. We diagnose autism and we gift it to others. So child doesn't come to you anymore, not for immunization, not for other issues. They will go to some allopathy, homeopathy, and they will take care of all these things. So here we are losing track with the patient, and hence vaccination may be missed. So that track pediatrician must give. And we must tell them that autism is not at all related, or it has nothing to do with MMR vaccine. So if they have any doubts, we need to clear that. Next, please. So what is the take-home message for pediatricians, for all pediatricians, grassroots level, village, anywhere? That pediatricians need to be aware of challenges in day-to-day practice while handling children with autism and adolescents with autism. Pediatricians need to rebuild trust in mind of parents. If you just diagnose and refer, they are going to lose trust in you. So spend some time, use the intervention tactics which Dr. Galwai has told in previous section. Pediatricians are the best resource and guide. Nobody else can guide them as good as pediatricians, because we know the development, we know the all the milestones, we know what are the factors affecting development. So we must stick to that. Next, please. Next. Proper counseling is needed to avoid medical shopping. So maybe once you have diagnosed, just give a separate appointment once and counsel the parent, and just give them confidence that if they have to, doubt in their mind, if they want to show it to somebody, they want second opinion, then you are the better person to guide them whom to show. If you don't counsel them, they'll just go for medical shopping. Role of medication should properly be counseled. Role of medication as autism or ADHD, and role of medication when they come for any other problem. Health, hygiene, and nutrition are very important to promote health, and this can be very helpful for these children with special needs. Last slide. Next.
Thank you, ma'am.
Also remember that parents are already stressed, and children with autism may not be very cooperative, so little bit of patience may be needed. And the last one is OPD waiting can be very frustrating, very embarrassing for parents. So this little thing what pediatrician can do and must do is give the priority appointment for these parents, so that it will be very comfortable and very easy for parent to come to you for any consultation. So these were some of the issues with day-to-day handling by pediatrician, where I almost experienced it many times. So I wanted to convey this. So thank you for giving me opportunity for this session. Thank you so much.
Thank you, ma'am. I request Anand Deshpande sir to.
Very, very nice overview. And basically they lose the contact, I feel, because there is a chronic element, and they get exhausted. Parental exhaustion is one of the most common thing. And resource exhaustion, what I've seen. Those who are rich, they can spend. Otherwise, for lower socioeconomic, they get resource exhausted. They cannot go for the therapy. So these are the many practical problems. So remaining with the pediatrician for a prolonged period is a problem for them because of the monetary reasons. That is one of the.
So that is why we give emphasis on parental training. So if the parents are trained, they can just some resources around them, and therapies may not be available at all places.
A mother as a therapy giver is the best option.
Yes.
Mother or parents.
Yeah, and pediatricians are available everywhere. So therapists may not be available. So pediatrician can be a great resource for the parent also.
I am going to suggest my AP to have some certificate course of 7-8 weeks, paid course for the Maharashtra IAPNs. So that some technical knowledge also pediatricians will get, those who are interested.
Yes.
Sort of at least certificate course of 8 weeks. Amol. You can have, which is very common thing
Yes,
now.
sir.
Have autism, and you can have a small certificate course which is paid, and the pediatrician will definitely pay and attend online course.
And little bit of I mean, this course will not only help for autism, but it will help for other disabilities.
Definitely.
Yes, yes.
Ma'am and sir has shared really like basic points and what like I am practicing in the remote area, ma'am. And here the lack of resources, lack of therapists, not a single occupational therapist in the city of Kolhapur. All are like some certificate course or something like that. So not a single person who is a proper degree holder or something like that. So basically, I prefer more with the home care centered approach. I teach my parents only, and I get a wonderful result because the patients are there with them for 23 hours. They are with us for just 1 hour maximum. So really, ma'am, all your tips are very useful for us to deal with the day-to-day practice.
Thank you.
Now, I would like to invite our next speaker, Dr. Ravindra Sonawane, sir. He is a general pediatrician and professor of pediatrics and head of the department in Dr. Vasantrao Pawar Medical College Hospital and Research Center, Nashik. He was also IIP President Nashik 2020, Treasurer IIP Nashik 2010, and he was an organizing secretary and workshop committee chairperson Pedicon in 2022 at Nashik, joint organizing secretary Mahapedicon State Conference 2021, and scientific chairperson Nashikon in 2017 and 2018. Sir is going to talk on ensuring the medical care, identifying the acute emergencies in children with autism. Over to you, sir.
Sir, presentation full screen nahi hote. Kindly make it full screen. Yes, sir. It is full screen now.
Start, sir.
Yes.
Kindly start, sir.
Ravi sir, start. Ravi sir, unmute yourself.
We cannot hear you, sir. We cannot hear you.
Cannot hear you.
I think there is a problem with his net connection, or I don't know.
Hello.
Phone cannot hear you.
Phone
No, sir. Sir, we cannot hear you.
Hello.
Sir.
आता येतोय आवाज.
Hello.
आला, sir.
Now we can hear you.
Now
Now we can hear you.
Sir, बोला.
Hello.
हाँ, बोला ना सर.
बोला, sir.
बोला, आता बोला.
आपका आवाज सुनाई दे रहा है सर.
I think some connectivity issue because
रवी सर, तुमचा व्हिडिओ ऑफ करा आणि फक्त ऑडिओ ऑन ठेवा.
He is not able to hear us. So,
Sir, rejoin व्हावं लागेल कदाचित.
मोबाईल करा.
एक मिनिट फोन
Amal
करतोय.
sir call करा. Amal sir call.
डिस्कनेक्ट करून परत रिकनेक्ट करू देत.
अमोल त्यांना फोन करशील.
केलाय.
बरं, इन द मीन टाइम मला एकच बोलायचं होतं.
हॅलो, मी मोबाईलने जॉईन होतोय.
हो.
काय आले?
हॅलो. सर तुम्ही व्हिडिओ ऑफ करा चालेल तुमच्या साईडचा,
हो
म्हणजे
हो,
आवाज
yes,
स्पष्ट येईल.
एक तो हा बंद करून टाकतो मी, दुसरा आहे बंद.
अरे आता ऑडिबल आहे, आता चालू ठेव.
सर दोन डिव्हाइस आहेत ना, मग इको येत होता आता मध्ये. आता अनम्यूट झालं, अनम्यूट करा ना सर. रवी सर अनम्यूट करा तुम्हाला स्वतः.
Oh, yes. So today's my topic is ensuring medical care, identifying acute emergency in children with autism. First I want to mention a disclaimer. I am actually general pediatrician. I am not a developmental pediatrician. समीर दलवाई सर आणि जया शिवलकर मॅडम हे डेव्हलपमेंटल पिडियाट्रिशियन आहेत आणि ते इंडियामधले टॉपचे डेव्हलपमेंटल पिडियाट्रिशियन आहे. कदाचित माझं त्यांच्या इतकं
सर तुम्ही पेडियाट्रिशियन डेव्हलप करता.
बरोबर.
हा तुमचा हंबलनेस झाला.
ओके ओके. नेक्स्ट स्लाइड प्लीज. मी माझ्या इथूनच करतो. येस, जस्ट 1 मिनिट. स्लाइड शो होत नाही.
पल्लवी मॅडम तुमच्याकडे घेतलंय का बॅकअपला?
हल्ली स्लाइड.
यस, कंटिन्यू प्लीज कंटिन्यू.
Yes, autistic spectrum disorder is a complex neurodevelopmental condition including impairments in social interaction, difficulty with communication, impairments in response to sensory stimuli, and repetitive stereotype behavior. आता हे तर आपल्याला सगळ्यांना माहित झालंय आणि त्याच्यात आपली PhD पण झालेली आहे. पण का इमर्जन्सीज आयडेंटिफाय करणं गरजेचं आहे ऑटिस्टिक चिल्ड्रन मध्ये, त्याबद्दल मी बोलतोय. With the increase in prevalence and significant comorbidity of medical problems, it is likely that medical professionals in the emergency and urgent care facilities will have increasing exposure to individuals with autistic spectrum disorder for urgent medical management, particularly acute behavioral dysregulation. When this occurs, it will be important to consider their special needs and understand the unique manner in which common medical problem may present in individual with ASD. आता सर्वांना प्रश्न पडला असेल की हा अमोल पालेकर कुठून आला. तर 3 दिवसापूर्वी समीर दलवाई सरांनी फोन केला की तुला अक्यूट इमर्जन्सीज इन ऑटिझम हे यावर तुला लेक्चर द्यायचंय. तर त्यावेळी माझी अवस्था ही अमोल पालेकर हे जे मोठे ग्रेट सेलिब्रिटी होते तर ते आहेत म्हणजे, तर त्यांच्यासारखी झाली. जर त्यांना अमोल पालेकरांना अचानक गोपीचंद जासूस किंवा करमचंद जासूस असा रोल दिला तर त्यांची अवस्था थोड्यासाठी गोंधळेल आणि ते कदाचित व्यवस्थित तो रोल करतील. पण माझी अवस्था आज तशीच झालेली. म्हणजे ऑटिस्टिक पेशंट मध्ये इमर्जन्सी चे सायन्स आयडेंटिफाय करणं हे एखाद्या जासूस पेक्षा पण अवघड काम आहे. तर आता हे जे आहेत ऑटिझमचे जे सेलिब्रिटीज, म्हणजे हा आहे आपला शाहरुख खान. तर त्याला ऍस्पर्जर सिंड्रोम झालेला असं दाखवलं गेलं होतं माय नेम इज खान मध्ये. ऍस्पर्जर सिंड्रोम हा ऑटिस्टिक स्पेक्ट्रम डिसऑर्डर मधला एक प्रकार आहे ज्याच्यामध्ये हाय किंवा नॉर्मल ऍव्हरेज इंटेलिजन्स असू शकतो आणि ते त्यांची वर्बल स्किल चांगले असल्यामुळे ते व्यवस्थित लाईफ इंडिपेंडंटली जगू शकतात. थोडंसं सोशलायझेशन मध्ये त्यांना प्रॉब्लेम येतो किंवा क्लमझीनेस त्यांच्यामध्ये असू शकतो. तर शाहरुख खानला त्या याच्यामध्ये ऍस्पर्जर सिंड्रोम म्हणून दाखवलेलं आहे. तर ऑटिझमचे असे पण काही भाग असतात की ज्याच्यामध्ये नॉर्मल किंवा हाय आयक्यू असू शकतो, हे त्या पिक्चर मध्ये दाखवलेलं होतं. आता ही प्रियांका चोप्रा बर्फीमध्ये, हिला पण एक 1970च्या सालातल्या एरियातला मध्ये हा म्हणजे त्या पिक्चर दाखवलं गेलं होतं बर्फी. त्याच्यामध्ये प्रियांका चोप्रा, तिचं नाव होतं झिलमिल, तिला सिव्हिअर ऑटिझम होतं आणि ती ज्याच्यावर प्रेम करत होती त्याचं नाव बर्फी, म्हणजे डीप आणि म्यूट होता तो, रणबीर कपूर. तर या दोघांची ती एक लव्ह स्टोरी होती. जरी या दोघांना प्रॉब्लेम्स होते पण तरी देवानी त्यांना एक ग्रेट गिफ्ट दिली, दॅट इज एक लव्हची गिफ्ट. सो हे जे 2 पिक्चर्स आहेत ते ऑटिझमशी रिलेटेड होते. बाकीचे बरेचसेच आहेत, डेव्हलपमेंटल डिले मध्ये कोई मिल गया वगैरे. तर आपला मेन जो टॉपिक आहे, वाय इट इज डिफिकल्ट टू डायग्नोज अँड ट्रीट अॅक्यूट इमर्जन्सीज इन ऑटिस्टिक चाइल्ड. तर हे जे ऑटिझमचे जे चिल्ड्रन असतात त्यांचे कॉग्निटिव्ह स्किल्स आर व्हेरी ऑफन डिफरंट. दिस इंडिव्हिज्युअल मे हॅव अ पुअर अंडरस्टँडिंग ऑफ कॉज अँड इफेक्ट, आणि त्यांचे पुढे काय जे होणार आहे त्याच्याबद्दल पण त्यांना काही आयडिया नसते. म्हणजे दे हॅव लिटिल कन्सेप्ट ऑफ कॉन्सिक्वेन्सेस. दे हॅव अ लिटरल रिस्ट्रिक्टेड रिजिड पॅटर्न ऑफ थिंकिंग, म्हणजे नाकासमोर चालणारं जे म्हणतो ना तसं. They often have a limited perspective of situations or circumstances and tend to view things as a right or wrong, yes or no, black or white. म्हणजे त्यांना फक्त आपल्याला हो किंवा नाही, चुकीचं किंवा बरोबर एवढंच ते इंटरप्रिट करू शकतात. कॉम्प्लेक्स गोष्टी त्या इंटरप्रिट करू शकत नाही. त्यांना जर विचारलं वेन, वाय, हाऊ, तर ते कदाचित उत्तर देऊ शकणार नाही. पण डिड यू गेट इट, मग येस किंवा नो, त्या याच्यामध्ये ते उत्तर देऊ शकतात. दे हॅव अन ऑब्सेसिव्ह डिझायर फॉर रुटीन अँड रिपिटेशन्स. म्हणजे समीर दलवाई सरांनी दाखवलं की जे त्यांना रिपिटेटिव्ह बिहेवियर असतं, टाळ्या वाजवणं किंवा सारखं गोल गोल फिरत राहणं किंवा मुव्हिंग ऑब्जेक्ट्स कडे सारखं बघत राहणं किंवा एखाद्या गेमकडेच बघत राहणं. तर हे त्यांच्यामध्ये त्यांना ती जी इच्छाशक्ती जी असते ऑब्सेसिव्ह असते. अँड दे ऑल्सो हॅव अ टेंडन्सी टू ओव्हर सिलेक्ट इरिलिव्हंट एन्व्हायरमेंटल स्टिम्युलाय. म्हणजे तेच की त्यांना जर पंखा आवडला किंवा बटन दाबायचं म्हटलं ते बटन दाबत राहतात किंवा इयरिंग्स कडेच बघत राहणार किंवा मोबाईलमध्ये एक विशिष्टच गेम खेळत राहणार. आणि एन्व्हायरमेंटच्या स्टिम्युलाशी ते एकतर हायपर रिॲक्ट होणार किंवा रिॲक्ट बिलकुल होणार नाही. तर देअरफॉर अ टीम ऑफ pediatrician, developmental pediatrician with paramedical health professionals will be required to treat these acute emergencies in autistic child like a CID team. जे CID टीम मध्ये सगळे आहेत. शिवाजी साटम आहे, तो दरवाजा तोडणारा दया आहे, किंवा आपला सायंटिस्ट म्हणजे फॉरेन्सिक जो साळुंके आहे. तर हे असे आहेत. फक्त आपल्याला इथे जो दया आहे, दरवाजा तोडणारा नको, तो त्या ऑटिस्टिक चाइल्डला सांभाळून घेणारा, शांतपणे बोलणारा आणि दरवाजा लागलेला असेल तर दरवाजा उघडून देणारा, पण दरवाजा ला लात न मारता किंवा न तोडता किंवा न आवाज करता. तर ही CID टीम सारखी आपल्याला अशी ही टीम लागणार. तर हे सर्वात महत्वाचं आहे की ऍप म्हणजे जे ऑटिझम साठी जो फ्रेमवर्क आहे, असेस, कम्युनिकेट आणि ट्रीट, हे जे एक ट्रँग्युलेटेड जे अप्रोच आहे, म्हणजे आपण त्रिमूर्ती बघतो किंवा त्रिदेव बघतो की ज्या पद्धतीने ब्रह्मा विष्णू महेश, की हे 3 ज्या गोष्टी आहेत त्या खूप महत्वाच्या आहेत. असेस, कम्युनिकेट आणि ट्रीट. तर याच्यामध्ये सर्वात पहिले असेसमेंट बघू. असेस द एन्व्हायरमेंट अँड बेस्ट अप्रोच ऑर कम्युनिकेशन मोड टू गेन ॲज मच ॲज इन्फॉर्मेशन ॲज पॉसिबल. म्हणजे तुम्हाला एन्व्हायरमेंट असेस करायचं आहे आणि बेस्ट अप्रोच किंवा कम्युनिकेशन मोड वापरायचं आहे जेणेकरून इन्फॉर्मेशन मिळते. प्रिपेअर अ क्वाईट एक्झामिनेशन रूम. म्हणजे एक्झाम रूम ही ती एकदम शांत असावी. एक सगळ्यांनी हा एक पिक्चर बघितला असणार आहे, क्वाईट प्लेस म्हणून. तर त्याच्यामध्ये जे असतात ते प्राणी असतात, म्हणजे जे वेंचर्स असतात ते विचित्र असतात, ते ब्लाइंड असतात, आंधळे असतात, पण नॉईजला सेन्सिटिव्ह असतात ते. तर ते बऱ्याचशा माणसांना मारत जातात, पण ते नॉईजनीच, जास्त नॉईज केल्यानेच ते मरतात. तर इथे जस्ट एक कंपॅरिझन केलेलं आहे. ऑटिझमच्या मुलांना एक्झॅक्टली की हे व्हॉइस किंवा आवाज हा नको पाहिजे असतो. मिनिमाइज सेन्सरी स्टिम्युलाय सच ॲज क्लटर, लाऊड इक्विपमेंट, ब्राईट ऑर फ्लोरसंट लाइटिंग. म्हणजे हे सगळं काहीच नको, म्हणजे लाईट नको, आवाज नको. म्हणजे इवन तो शोले मधला एके हंगल येऊन म्हणायला पाहिजे, इतना सन्नाटा क्यू है भाई. तर तेवढा सन्नाटा आपल्याला एक्सपेक्टेड आहे जेव्हा आपण ऑटिस्टिक चाइल्डला बघतो आपण. मिनिमाइज पर्सनल टू ओनली द इसेन्शियल. वन व्हॉइस अप्रोच, म्हणजे फक्त एक माणूस, म्हणजे एका वेळी एकच माणूस बोलणार, खूप मल्टिपल व्हॉइस नको. म्हणजे अकेला बरा हमपेक्षा. डिटरमाइन द बेस्ट वे टू अप्रोच or communicate with the individual and gain as much much information as possible from both parents and caregiver. Now communication to gain history, examine and evaluate the individual. Approach the individual slowly and calmly, keeping some distance between you and the patient. म्हणजे आपल्याला इथे सस्याच्या ऐवजी कासवाचा वेग पकडायचा आहे आणि हळूहळू त्याला अप्रोच व्हायचा आहे. आपल्याला काही म्हणजे घाई नाहीये, अर्जन्सी नाहीये. म्हणजे जे म्हणतात ना, अति घाई संकटाला नाही, ती अति घाई नको. इथे सेन्स ऑफ अर्जन्सी बिलकुल दाखवायची नाही. वी हॅव टू बी व्हेरी पेशंट आणि कामली ते अप्रोच व्हायचंय. यूज द पर्सन्स फर्स्ट नेम, म्हणजे पिंकू, पिंटी, जे काय असेल, पप्पू, अशा नावाने त्याला पुकारा. अश्युअर दॅट यू आर देअर टू हेल्प. त्यांची सात्वना करा की आम्ही इथे मदतीलाच बसलोय. टॉक इन क्वाइट काम वाईज. ट्राय टू इस्टॅब्लिश रॅपो नो मॅटर हाऊ द अर्जंट सिच्युएशन. डू नॉट अटेम्प्ट टू टच, ग्रॅब or restrain without preparing the individual first if possible. Before examining, tell the individual what you are going to do or want him or her to do. Ask simple yes or no questions. म्हणजे avoid questions or sentence that require complex response. म्हणजे तुम्हाला असं did you drink water? Yes or no? Yes. पण जर तुम्ही विचारलं what amount of water you drink, how, when, so that autistic child will not be possible that for that child to give answer. So ask simple yes or no questions. Allow the person time to calm down and added time to them to process and respond. तर थोडक्यात की आपल्याला इथे योगी स्टाईलनी, एकदम साधू ऋषी स्टाईलनी सात्वना करून मुलांना त्या अप्रोच व्हायचंय आणि त्यांच्याशी कम्युनिकेशन साधायचंय. आणि नंतर ट्रीटमेंट युझिंग केअर अँड कन्सिडरेशन ऑफ इंडिव्हिज्युअल युनिक कॅरेक्टरिस्टिक्स. कन्सिडर सेन्सरी इश्यूज सच ॲज मेडिकेशन टेस्ट, कशी आहे त्याची, गोड आहे, ते आंबट आहे, कडू आहे, स्मेल. त्यानंतर टेक्स्चर म्हणजे स्मूथ आहे की रफ आहे, टेम्परेचर हॉट आहे, कोल्ड आहे, temperature of treatment materials. Show all the material prior to using them and let the patient touch them if possible. म्हणजे ते एखादी जी पण वस्तू असेल, इक्विपमेंट वगैरे, तर त्याला हात लावू दिला पाहिजे. बऱ्याच वेळा त्या मुलांना असं वाटतं की त्या इक्विपमेंटमुळे मला त्रास होणार आहे किंवा ते पेनफुल असणार आहे, त्यामुळे ते घाबरतात. आणि एकदा त्यांनी ते टच केलं किंवा त्यांना त्याच्याबद्दल आयडिया दिली तर ते शांत होऊ शकतात. त्यानंतर मॉडेल द इंटरव्हेन्शन ऑन द केअर गिव्हर. म्हणजे जे आई वडील आलेले असतील पॅरेंट्सवर, तर त्यांच्यावर ते इंटरव्हेन्शनचा एक नमुना आपल्याला त्यांना पेश करायचा, जेणेकरून त्यांच्या मनातली भीती ही चालली जाईल. त्यानंतर कव्हर स्प्लिंट्स और बँडेजेस विथ non-threatening images for pediatric or adolescent patient with ASD. This ACT provides framework for response from healthcare providers. Following the ACT framework when responding to emergency situation may help the interaction have a more positive outcome. याच्याने आपल्याला जास्त पॉझिटिव्ह आउटकम मिळू शकतं. आता इमर्जन्सी सिच्युएशन दॅट कॅन इन्क्रीज जर चाइल्ड तो लाऊड अनफॅमिलियर साईट्सला किंवा साऊंड्सला किंवा त्या पीपल्सला किंवा इव्हेंट्सला जर तो एक्सपोज झाला तर त्याच्यामुळे त्या मुलाची अँझायटी वाढू शकते. सो इट इज इम्पॉर्टंट फॉर इमर्जन्सी पर्सनल टू टेक नेसेसरी स्टेप्स टू रिड्यूस अँझायटी अँड इन्क्रीज अंडरस्टँडिंग. आता काही फार्मॅकोलॉजिकल इंटरव्हेन्शन्स लाईक बेन्झोडायझेपिन किंवा केटामाइन म्हणजे जे थोडे सेफ आहेत, ते त्यांच्यानी खूप कमी डोसमध्ये जास्त साईड इफेक्ट्स नाही, ते आपण अशा पेशंटला अँझायटी किंवा ॲगिटेशन कमी करण्याकरता आपण वापरू शकतो. फिजिकल रिस्ट्रेंट वापरायचे का? शक्यतो फिजिकल रिस्ट्रेंट हे अवॉइड केले पाहिजे. दे मे एक्झॅबरेट अँझायटी अँड ॲगिटेशन. जर लागलेच तर त्या मुलांना आपण ब्लँकेटमध्ये टाईटली व्रॅप केलं तर ते चांगलं राहील, की जेणेकरून त्यांचे आर्म्स आणि लेग्स आणि बॉडी हे एकत्र राहील. म्हणजे ती जेव्हा आपण आर्म आणि लेग रिस्ट्रेंट वापरतो हे बॉडी पासून आर्म आणि लेग जे दूर जातात आणि ब्लँकेटचं जनरली हे स्मूथ स्ट्रक्चर असतं त्यामुळे मुलांना त्याच्यात कम्फर्टेबल वाटतं. तर नाव हे जे ॲगिटेशन जेव्हा ऍक्यूट इमर्जन्सी मध्ये येतात तर त्यांचे ते ॲगिटेशनचे कॉजेस काय असतात? तर GIT एलिमेंट्स लाईक कॉन्स्टिपेशन, स्लीप डिसऑर्डर, झोप झालेली नसेल, इन्सोमनिया असेल, डेंटल पेन, मेन्स्ट्रुअल पेन, त्यानंतर ऑकल्ट ट्रॉमा इन्क्लुडिंग टू हेड, आर्म्स, आईज. तर अशा या सगळे हे जे आहेत बॉडीचे सगळे पार्ट्स हे व्यवस्थित एक्झामिन केले पाहिजे की जेणेकरून आपल्या ॲगिटेशनचे कॉज शोधता येतील. नाव ह्या मुलांमध्ये SIB असतं, सेल्फ इंजुरियस बिहेवियर. तर ते हेड बँगिंग करून हेड इंजुरी म्हणून येऊ शकतात. युझिंग ऑब्जेक्ट्स टू कट ऑर पंक्चर सेल, तर कट वुंड्स घेऊन येऊ शकतात. पिंचिंग सेल किंवा काही इनएडिबल सबस्टन्स कन्झ्युम करून येऊ शकतात, पॉयझन वगैरे किंवा मेडिसिन्स. पुलिंग ऑन हेअर, बीटिंग, स्क्रॅचिंग बॉडी पार्ट्स. तर ह्या ॲगिटेशनला आपण कसं अप्रोच झालं पाहिजे? तर ऑलरेडी आपण काही पॉइंट्स डिस्कस केलेले आहेत. त्यामध्ये पहिला पॉइंट, इनिशिएट इव्हॅल्युएशन, शुड अंडरस्टँड चाइल्ड्स टिपिकल बिहेवियर. त्यानंतर हिस्ट्री घेतली पाहिजे, कम्युनिकेशन स्किल, मोटर स्किल, सोशल स्किल वापरले पाहिजे. एन्व्हायरमेंटची अडॅप्टेशन म्हणजे क्वाईट रूम, लो लाइटिंग वगैरे वगैरे ते झालंय. कम्युनिकेशन त्यांना अँझायटी कमी करण्याकरता वर्बल अँड नॉन वर्बल मेथड्स ऑफ कम्युनिकेशन वापरले पाहिजे. त्यानंतर बेस्ट स्ट्रॅटेजीज सर्टन बिहेवियर मॅनेज करण्याच्या वापरल्या पाहिजे. सोमॅटो सेन्सरी इंटरव्हेन्शन्स म्हणजे रिलॅक्सेशन टेक्निक्स लाईक ऑडिटरी, टॅक्टाईल, व्हिज्युअल, ऑल्फॅक्टरी, फिजिकल एक्सरसाइज त्या वापरल्या गेल्या पाहिजे. आणि सर्वात शेवटी रिस्ट्रेंट, तर दिस शुड ओनली बी यूज एज अ लास्ट रिसॉर्ट when other method have failed and the patient poses a risk to themselves and others. शक्यतो हे रिस्ट्रेंट हे वापरायला नको. तर हे ऑटिझमचे जे क्लिनिकल कंपेनियन्स आहे, तर इपिलेप्सी और सीझर, स्लीप डिसऑर्डर, ADHD, गॅस्ट्रोइंटेस्टायनल डिसऑर्डर, फीडिंग चॅलेंजेस, ओबेसिटी, अँझायटी, डिप्रेशन, बायपोलर डिसऑर्डर. तर याच्यामध्ये इमर्जन्सी डिपार्टमेंटमध्ये आल्यानंतर कोणत्या गोष्टींचे अवेअरनेस आपल्याला पाहिजे? तर फर्स्ट, इपिलेप्सी और सीझर डिसऑर्डर. 40% ऑफ ऑटिस्टिक baby child will develop epilepsy or some other seizure disorder by the end of adolescence. Consider the possibility of seizure when dealing with individual with autism when patient present with altered mental status. Management of ASD patient with seizure or multiple seizure is similar to non-ASD patient. Now, त्यांचे symptoms काय असतात? Repeated unexplained abrupt changes in behavior such as staring spell, अचानक एकदम शून्य नजरेने वरती बघत राहतात, जसं ऍब्सेंट सीझर सारखं, किंवा स्टिफनिंग ऑफ मसल्स, किंवा इनव्हॉलंटरी जर्किंग ऑफ लिम्स, किंवा सडन स्लिपीनेस और स्लीप डिस्टर्बन्स. म्हणजे हे सिम्पटम्स सीझर डिसऑर्डरचे असू शकतात. काही वेळा सडन अनएक्सप्लेन मार्क इरिटेबिलिटी और ॲग्रेशन और रिग्रेशन इन नॉर्मल डेव्हलपमेंट असे पण प्रेझेंटेशन सीझरचे असतात. नाऊ सेकंड इमर्जन्सी जे कॅटाटोनिया. कॅटाटोनिया ही मेडिकल इमर्जन्सी आहे. ती 17% ASDच्या पेशंटमध्ये आढळते. दॅट इज डिफाईन्ड बाय डिक्रीज स्पीच और मोबिलिटी, freezing during actions, posturing, staring, negativism, or ecophenomenon. That is called as shutdown syndrome. Initial evaluation include careful history, physical examination to rule out other possible diagnosis, and use lorazepam challenge test, where 1 milligram is given to the patient with monitoring for symptomatic improvement. If there is no response, second dose may be given. Now, if catatonia is confirmed, inpatient hospitalization is required for further lorazepam treatment or ECT therapy, electroconvulsive therapy. Now, sometimes child with autism may eat non-edible product that called as pica. Sometimes they may consume poison or some medications. Many individuals with autism have a poorly developed upper trunk area, which puts them at greater risk for positional asphyxia. So, काय स्टेप्स घ्यायला पाहिजे अशा पेशंट मध्ये पोझिशन सारखी चेंज करत राहिलं पाहिजे अँड त्यांचा चेहरा खाली नाही पाहिजे, नॉट कीपिंग देम फेस डाऊन. दिस इज स्पेशली इम्पॉर्टंट वेन कन्सिडरिंग रिस्ट्रेंट. जेव्हा रिस्ट्रेंट लावतो त्यावेळी ह्या गोष्टी आपल्याला म्हणजे फेस हा डाऊन नाही पाहिजे. बास्केट मेथड मध्ये जे वापरतो ती मेथड नाही वापरली गेली पाहिजे याच्यामध्ये. आता GIT डिसऑर्डर्स, गॅस्ट्रोइंटेस्टायनल डिसऑर्डर्स, तर याच्यामध्ये लहान मुलं कसे प्रेझेंट होऊ शकतात ते एक तर आर्चिंग द बॅक, प्रेसिंग द बेली और ग्रिटिंग द टीथ अशा पद्धतीने प्रेझेंट होतात. डायरिया, कॉन्स्टिपेशन, गॅसेस और पेनफुल बॉवेल मुवमेंट्स ह्या पद्धतीने ते पेन GIT प्रॉब्लेम्समुळे क्रिएट होतो आणि ते अशा पद्धतीने प्रेझेंट होतात. आता GID चे, गॅस्ट्रोइसोफेगल रिफ्लक्स डिसीजचे, they might strain the neck, push out the jaw, tap the throat, avoid lying down, experience sleep disruption or refuse food. तर हे GIT सिम्पटम्स किंवा GID अशा पद्धतीने येऊ शकतात. फीडिंग प्रॉब्लेम याच्यामध्ये दोनच गोष्टी महत्वाच्या आहेत की सिलेक्टिव्ह इटिंग आणि ओबेसिटी ह्या कॉमन फीडिंग डिसऑर्डर्स आहेत. सेन्सरी इश्यूज, अँझायटी, मेडिकेशन साइड इफेक्ट, सोशल आयसोलेशन आणि ऍक्टिव्हिटी लेवल या अंडरलाईन फॅक्टर्स यांना फीडिंग प्रॉब्लेम्सला प्रिसिपिटेट करतात. नाउ स्लीप प्रॉब्लेम्स, क्रोनिक स्लीप प्रॉब्लेम्स 50 ते 80% पेशंट मध्ये असतात. डिफिकल्टी इन फॉलिंग asleep, frequent and prolonged wakening and extremely early rising. आणि sleep issues go hand in hand with daytime behaviors and affect quality of life for entire family. So general sleep hygiene intervention can help, and specialists have created parent-guided programs to help improve sleep in children with ASD. आणि लास्ट, anxiety disorders मध्ये मुलं anxiety मुळे they can trigger racing heart, muscle tightness, stomach ache, and some people may even feel frozen in place. आणि काही जणांना सोशल अँझायटी पण डेव्हलप होऊ शकते. जवळजवळ 42% मुलांमध्ये ती आढळते. तर एकंदरीत मी शॉर्ट मध्ये अॅक्यूट मेडिकल इमर्जन्सीज मध्ये आपण काय काय बघितलं पाहिजे ते मी हे सांगितलं. ही जे चित्रफित आहे ती ब्लॅक मूवी मधून आहे. तर याच्यामध्ये अमिताभ बच्चन जो टीचर आहे त्याला अल्झायमर डिसीज असतो आणि ही जी राणी मुखर्जी आहे ती डीप आणि म्हणजे ब्लाइंड, डीप म्यूट ब्लाइंड आहे. तर दॅट वॉज द कॅथर्टिक टेल ऑफ यंग वुमन हू कॅनॉट सी, हिअर और स्पीक, and the teacher who brings a ray of light into her dark world. This groundbreaking film shows two people teaching each other that life is full of possibilities only if we are willing to see. So this is about my presentation. Thank you.
Superb. Nice presentation.
Really, sir, great presentation. Most difficult topic in a most simplified way. Seriously. Because see, when we are dealing with this autistic children, and they come to us. Actually, they are in pain or they are getting some or other agitations, and it is very important for us to find out the meltdowns in them. Sensory meltdowns we need to understand, and sir has managed all the sensory issues very nicely in his topic. Seriously, sir, thank you. Jaya madam, you want to say something?
Thank you, Krishna.
Yeah, actually, all these three topics are complementary to each other, and everybody who is dealing with special children should be aware of all these three: bit of intervention, bit of handling of daily issues, and bit of handling of emergencies. That will really increase the confidence of pediatrician to deal with these children, because normally what we are seeing is children are plain and straight referred to autist, and that is not a very good thing to do. So I think this session has really served the purpose to make the pediatricians empower, be confident, and they can handle. Having Sir Ravindra sir on the panel itself suggests that we all can do it.
Yeah.
Thank you, madam.
Seriously, it's a great session. So now moving further, I would like to invite Dr. Amol Pawar sir for his concluding remark.
Thank you, Kashmiri. Thank you for moderating this very important session with stalwart speakers and stalwart chairperson and stalwart delegates too. I thank Dr. Ramakant Patil sir, Dr. Bodhankar sir, Dr. Anand Deshpande sir, then Dr. Samir Dalwai sir, who is not there now. He has gone for another meeting. Then Dr. Jayasri Shevalkar madam, she has done all the work. Credit goes to her for this webinar, because last year also whole week was celebrated, and her ideas were taken into account. And Kashmiri also. Kashmiri is a Kolhapur IIP secretary. She is busy celebrating IIP, celebrating Autism Day and Week in Kolhapur Academy of Pediatrics. But still she has given time. Also, thank you, Neha. Thank you, Vishal. Thank you, Pallavi madam, for these flyers and messages and all these things. Thank you all delegates for listen hearing, and will have webinar on Sunday for teachers and parents also. That will be in Marathi, and Jaya madam will be there guiding us, and another 2-3 speakers will be there. So thank you all,
Tomorrow I
Maha-IPNs.
will share the details.
Yes, ma'am.
Tomorrow I will share the details.
Yes, yes. Thank you, ma'am.
Thank you. Thank you.